ADT is standard treatment for metastatic disease, as we just heard, possibly with local radiation or surgery. There are certainly other places where ADT is standard of care, but it doesn't come without a price. So the question is, what can we do about that and how to minimize those? And I'll actually show you the results. I know for those of you in the audience, on Thursday I alluded to it. We've actually done a prospective randomized trial in this setting of how to try and reduce some of these ADT side effects that I'll review. So ADT is, I'm not sure where the colors are right, but it is frequently used in patients that should be getting it. We tend to, which would be high-risk radiation patients, we use it quite frequently. We actually, unfortunately, use ADT for inappropriate use. I think that's been declining as we're learning more about the metabolic side effects of ADT. Lower reimbursement for ADT has certainly changed that inappropriate use as well. But even when it's not clear what the right answer is, we tend to use a lot of ADT. So it's certainly a very common treatment. In terms of prostate or testosterone, we know it's a key growth factor for prostate cancer. But if you think about it, and think about to me, kid, but a teenager, someone trying to make the high school football team or trying to make the professional big leagues in baseball, who's taking steroids, which essentially is various forms of testosterone, promotes muscle mass, reduces fat mass. And so imagine ADT, now we're essentially reversing that. We're having the exact opposite. It does peak in puberty, which is always an interesting question. Why did we get prostate cancer in our 60s, 70s, and 80s, and testosterone is highest when we're teenagers? But that's a separate question for a separate time. And it slowly declines throughout life. There is no clear andropause. In terms of ADT, as I said, it's the exact opposite of what we see with testosterone. So it's very effective for the prostate cancer, but the muscle mass shrinks and we get increased fat mass. And that's been very well documented across many studies nowadays. And this is just one of those studies highlighting that. This is a 2-year prospective study they included healthy controls, men not on hormonal therapy with prostate cancer, men who were initiating hormonal therapy, and men who had been on hormonal therapy for a long time. And what you can see here is in terms of body fat going up, particularly in the patients newly starting ADT, but even the patients who've been on chronic ADT for years, you continue to see the fat mass going up here, going up slightly here. And for the control patients, you don't see a whole lot of change. If we look at lean body mass, again, for the acute ADT, huge drops, but even in the other ones, you get slight. And this is essentially the same way, but just reporting it slightly different in terms of percentages. So a study that we had conducted was to look at how much weight do men gain, keeping in mind that they're losing muscle mass and gaining fat mass. So you could say, theoretically, the weight change may actually balance each other out. So we looked at 132 men who were starting hormonal therapy. They were all starting at post-prostatectomy for a rising PSA. And what we found was, if you look here, in the year before ADT, there really wasn't much of a weight change. In the year after ADT, they gained about 2 kilos, so about 4.5 pounds, and then was relatively stable. So again, that's purely based on body weight. We do know that the continuing changes of putting on fat mass, losing muscle mass do continue much slower. Much of that occurs in the first 6 to 12 months, and that's what we see here. We see about 4.5 pounds of weight gain in the first year and not a lot of change after that. So switching gears a little bit to, just the what we see in terms of body comp, but the influences this has is particularly on insulin. And insulin is a hormone produced in response to glucose intake, and its largest site of uptake is in the muscles. So that's why we talk about exercise being helpful for glucose control in diabetics, because it builds the muscle mass, increases glucose uptake in the muscles. So if you're shrinking your muscles, you're going to end up with insulin resistance. And this was a nice study done by Matthew Smith where they actually looked at this, and what you see is here, these are patients at baseline and 12 weeks after starting hormonal therapy, and you see the glucose levels themselves didn't actually change, but the amount of insulin you needed, your body produced to generate those same levels of glucose went up significantly. So this is what we would call insulin resistance. Once the glucose levels start to actually go up, that would be diabetes. So we can see here in a modest-sized study, it's clearly worsening insulin resistance. Well, how about actual frank diabetes? We see that it causes insulin resistance. It makes sense in terms of the mechanism, but does it actually cause diabetes? So this is one of the early studies by Nancy Keating, using data from the SEER analysis, 73,000 men, and what they showed is that hormonal therapy increased the risk of developing diabetes by 44%. 44% increase. So if you were going to have a 10% risk, it's now 14%. So if your risk to develop diabetes was pretty low, this is a 44% relative increased risk. So if your risk to develop diabetes was relatively low to begin with, 44% higher is relatively modest. But for your average man, 70% of Americans are overweight or obese. A lot of them have some level of insulin resistance to begin with. So for those men, a 44% relative increase is actually quite dramatic. So another study from Nancy, using VA data this time, showed a 28% increased risk. So two very large studies in very different settings came to the same conclusions. What else do we know? In terms of that hormonal therapy actually increases lipid levels. Particularly it increases triglyceride levels, it increases cholesterol, increases LDL cholesterol, but actually increases HDL cholesterol. And HDL cholesterol is classically taught as that's the good cholesterol. There's actually some very interesting data coming out now that HDL may not be as good as we thought it was. There's some meta-analysis showing no link between HDL and cardiac disease. Kind of makes sense in that many drug companies have developed drugs that actually raise HDL quite effectively, and in clinical trials they don't reduce cardiac effects at all. So now that kind of goes against the dogma of HDL being good cholesterol, but I think in a minority camp where HDL is probably neither good nor bad cholesterol. But nonetheless, your classic metabolic syndrome that we talk about would be all of those, except HDL would go down. So ADT is not exactly the same as your classic metabolic syndrome. And actually, if you look here, what you see, and this is a slide I stole from Matthew years ago, if we compare in terms of the classic metabolic syndrome, so your overweight, obese person who's developing lipid abnormalities, insulin resistance, and how does that compare to ADT? They both get obesity, abdominal obesity, both have reduced insulin sensitivity, increased resistance, triglycerides go up. But if you look at where the fat is, in the metabolic syndrome, it's visceral fat. That's the one that we think is most tightly correlated to cardiac dysfunction, cardiac events, whereas in the ADT, it's actually subcutaneous. So it's different. In terms of HDL cholesterol, decreased with the metabolic syndrome, increased with here. So it's a little bit different than the classic metabolic syndrome. And this is important because if we look at the metabolic syndrome, we see how common it is, particularly among men in the age range of prostate cancer where we're treating them, 40-50% already have pre-existing metabolic syndrome. And the downside of the metabolic syndrome is it's based upon several different criteria in terms of your glucose, your HDL levels, and your BMI, and different measures. And so you can actually look at men who have none of the parameters versus all four abnormalities. And the risk of a cardiac event or developing diabetes here goes up dramatically. So we're at the point here where if they're coming in the door they could have, a nearly 15% risk. And this isn't men who are 40 to 59-year-olds. This is not the 70-year-old that we're treating with prostate cancer who's likely to develop coronary events. And actually more likely, what's an interesting fact is men diagnosed with prostate cancer who walk in the door with prostate cancer diagnosis are actually more likely to die of heart disease than die of prostate cancer. It's the number one cause of death among men with prostate cancer is heart disease. So if we look at the 20-year risk, which is now putting them into the age range of prostate cancer, for those higher-risk guys, about 1 out of 4 are developing actually an event or diabetes or both. So what do we know? We've kind of been hinting around the cardiac effects in terms of insulin resistance. Diabetes is a risk factor for heart disease, poor cholesterol, losing your muscle mass. So what do we actually know about cardiovascular disease? And the short answer is it's controversial. And if we look at observational studies, and we just heard a great example from Dr. Stock in terms of observational studies that may or may not be telling us the right answer. We don't know. And that's why ultimately we need to be doing the randomized trials, but we can get some hints from that. So if we look at observational studies, non-randomized, tremendous selection bias of who gets hormones and who doesn't. What we see is consistent, for the most part, study after study after study, showing if you get hormonal therapy, it increases the risk of cardiovascular disease. And it tends to happen early. So there's a nice study that showed it really starts this increased risk within the first 12 months, which goes along with the data of that's when you're getting the metabolic side effects quite early. Some studies it's 20% higher. If we just look at cardiovascular disease, if we actually look at cardiovascular mortality, in another study it was 160%. And another one that if you looked at men, older men, who, and this was actually now a randomized trial of those who got radiation with hormones versus radiation alone, there was a shorter time to fatal MI. Not just developing cardiovascular disease, but actually dying of an MI. Again, going back to Nancy's data from the SEER analysis, we talked about higher risk of diabetes, but there's also, it's more modest, but there was significant increased risk of heart disease, MI, and again, sudden cardiac death. If we looked at the VA analysis, same conclusions, though they actually added stroke as well in terms of, again, a thrombotic event. And it seems to be more thrombotic acute events than kind of heart failure, the slow deterioration of the heart. It seems to be perhaps, there's some very interesting data in terms of ADT and macrophages in terms of inflammation, that it may lead to plaque disruption. So there's some thought maybe it's the guys who have pre-existing disease to begin with. Still a lot of basic science to be worked out. So, but as I said, the data linking it ADT with heart disease are really observationals. And we know in those studies men are not randomly assigned. But we often will say, oh, you're too sick to have surgery or radiation, so we'll just put you on some hormonal therapy. So what do we see when we look at randomized trials? We actually see, for the most part, nothing. And this was a nice meta-analysis that Paul Wynn had done, published in JAMA a few years ago now, that looked at over 4,000 men from 8 different trials and absolutely no difference in cardiovascular events, or death in this case. But we know in the right setting, ADT reduced prostate cancer deaths and actually reduced all-cause death by a smaller amount because some of these men were dying of prostate cancer. So the challenge is trying to put these two pieces together. We have this observational data that are pretty consistent. There are some outlier studies that say no increased risk, but most say you do. Most clinical trials say no effect. And to me, the way I kind of reconcile these data in my mind is if I have a patient who's healthy enough to go on a phase 3 trial, and I'm going to follow him like he's on a trial, ADT is probably reasonably safe, cardiac-wise. There's actually data that men who go on phase 3 trials and are randomized to standard of care arms actually do better than the men who never got on the trial. So A, it's a selection bias, but B, we follow patients very closely. They're meeting the coordinator or study coordinator every 3 months, and, I'm doing okay, but the other day I had a little chest pain when I was, standing up and walking around. Chest pain. Write that down, let the PI know. Oh, chest pain, you got to go see your cardiologist. Or if they're a standard of care patient, you may not be asking those questions. We really should be, but we may not be. So I think in a tightly controlled setting, ADT is quite safe. If we're talking men who have some pre-existing cardiac disease and things that we're worried about, it may be reasonable to send them to the cardiologist, because I do think there's enough data there to suggest something is going on. So this was a study from Anthony D'Amico where he looked at 206 men with intermediate risk prostate cancer. And again, this was his randomized trial of of radiation versus radiation plus hormonal therapy that showed an overall survival benefit for the combination of hormonal therapy. This has really influenced our care since then in terms of intermediate risk adding hormonal therapy. But it's interesting, if you look at the healthy patients, no or minimal comorbidities, you see a pretty clear separation with hormonal therapy increasing survival. But if you looked at the patients who had moderate or severe comorbidities, the curves are nearly overlapping early, but actually tend to separate slightly later, showing hormonal therapy certainly had no benefits, and actually with the p-value of 0.08, actually said maybe it's harmful. Maybe it's actually worsening survival. So again, very interesting hypothesis generating data. So something that I'm very interested in is if we're creating this metabolic syndrome, we're raising cholesterol, we're raising insulin, what does that do to the cancer? And are we in a way undercutting the potential benefits of ADT by raising these growth factors for prostate cancer? And can we actually make ADT more effective, safer and more effective? So again, insulin leads to diabetes, but it's actually a prostate cancer growth factor. You take, as I mentioned on Thursday, you take prostate cancer cells in a petri dish, you add insulin, cells grow faster. So the question is, in mammals, we know that slower prostate cancer growth occurs with lowering insulin. The question is, what do we know in humans? So this was, again, a mice study here, where 20 mice per group. I know not all of us are believers in mice studies, but for me, that's where we get our ideas from, which we ultimately need to then translate into clinical trials. And they did a high-fat, high-carb versus high-fat, low-carb. So again, lowering carbohydrates, and what you see is dramatically lowering insulin levels and slowing tumor growth. So this is a study that we had done, and for those of you who are here on Thursday, I did show this data, I think briefly. It's a little bit more expanded. Again, so we did a low-fat, but also a low-carbohydrate, kept calories the same, we lower insulin, and we prolong survival in the mouse. So, and we actually have, so the question is, I think we can do better oncologically if we can control the metabolic side effects, but to be able to do that, we first need to show that they're preventable. So many ADT side effects do stem from insulin resistance. As we said, insulin is a hormone your body produces when you eat sugar. So the question and the hypothesis, I guess I should state, that we had was that an extreme low carbohydrate diet will prevent insulin resistance as well as other metabolic side effects in men starting hormonal therapy. So to do this, we conducted a prospective randomized controlled trial of an extreme low carbohydrate diet versus control for 6 months in men starting hormonal therapy. And we defined our low carbohydrate diet as 20 grams of total carbohydrates per day. So you do the math, 20 grams times 4 calories per gram is 80 calories. These men lost a fair amount of weight, as you'll see, probably consuming about 1,600 calories. So it takes about 5% carbohydrate intake, assuming they actually listened to what we suggested. The men were actually also instructed to exercise, though we've seen randomized controlled trials of exercise that showed no effects on insulin resistance. So I don't think our effects were mediated by exercise, but we can't exclude that possibility. And then again, the control arm was asked to make no changes. Don't start exercising more, don't start exercising less, don't change your diet, keep doing what you're doing. So it's actually kind of challenging to find a man who is willing to make dramatic lifestyle changes based on a flip of a coin, but equally happy to make no change at all. We often see men who come in who say, I'm committed to changing my lifestyle, just tell me what to do. That man we can't actually put on the trial because he would mess up the control arm if he were on the control arm. So it's actually hard to find these men. It took us a while, but we eventually did. And we enrolled 45 patients. We randomized 42, and we lost a couple even before the baseline. So we had 40 patients, of which ultimately 29 completed the study. So a couple of them we didn't have complete data on, so actually 34 completed the study. So it's about 95% completion rate from the control arm. It was actually about 75% in the low carb. So we did lose some patients for sure, but 75% were able to complete the 6-month study. And if we look at baseline characteristics, it's what you would expect from men starting hormonal therapy. Age mid-60s, was mostly white. We did it as a 2-site study. Weight, and if you look at in BMI, we required them to have a BMI above 24, with the idea that they're going to be losing weight, so we wanted them to have a little bit of excess weight to lose. So that's why our BMI is a little higher than the average American, but not that much higher. And you see glucose levels were normal. Our primary outcome was insulin in the study, so we excluded all diabetics. So these were non-diabetic men. They couldn't be on medication that affected insulin, metformin, steroids, anything of the sort. And their PSA levels, again, consistent with men starting hormonal therapy. And we'll walk through this one by one. If we look at HOMA, which is a measure of insulin resistance, we saw significant changes at 3 months and very suggestive, but not quite statistically significant in an underpowered study at 6 months. But as you see in this study, again, insulin resistance went up 36% in the control arm. That's what you would expect. Because one of the questions is, does the control group, because you told them how bad sugar is, we're doing this trial, we think sugar is the enemy, oh, sorry, came up heads, don't actually make any changes in your diet. So the question is, did they actually make some changes? Well, they did. Certainly their insulin resistance went up 36% and actually completely null in those randomized to the extreme low-carb diet. If we look at PSA changes, they went down very much in both arms. ADT is good cancer therapy. We know that. And this study wasn't designed to test whether the low-carb was more effective at cancer control. That's going to need to be for future studies. If we look at weight change, this was by far the most dramatic. The control arm gained 1.3 kilos, again, about what you would expect from a control arm at 6 months, but those on the intervention lost 9.3. So the difference was 10.6 kilos or 23 pounds at 6 months. So we have not yet crunched the data to see what they actually ate, but to me, they're doing something because it's not a lot of studies out there that can get 23 pounds of weight loss despite going on hormonal therapy in 6 months. What's amazing to me is we actually blocked the osteoporosis. Bone mineral content was unchanged. Whether that's related to the exercise, I have a hard time believing just telling someone to exercise 30 minutes a day, 5 days a week. We gave them pedometers, but it was not supervised, wasn't intensive, wasn't weight. Yeah, it was weight bearing, but it's hard to imagine that alone blocked osteoporosis when prior studies of exercise have not shown this effect. So something's going on with the diet, and again, putting on 11% increase in fat mass versus loss of 16% fat mass. So in terms of preventing the side effects, for what we learned from this study, it's still unpublished. It was presented at the AUA last year, 2016. We're in the process of still writing it. Among men starting hormonal therapy, a low-carbohydrate diet suggestively prevented insulin resistance. Original power calculations said we needed 100 patients. Again, it was a struggle to find the patients. So we ultimately had 40, so it was underpowered. It did prevent bone loss, surprisingly, and led to significant weight loss and reduced fat mass. And we actually are in the process now of testing whether this diet will actually slow tumor growth. That is currently ongoing. So in summary, ADT use is common, but has side effects. It induces a metabolic-like syndrome, but it's not the classic metabolic syndrome. It does differ in potentially important ways. And we certainly know it increases diabetes risk. That's pretty well established. When that data was first coming out, the FDA actually put black box warnings on hormonal therapy. This is associated with increased risk of diabetes. So that's pretty well established. The effect on cardiac function, we don't know. And cardiac disease, my opinion is that it actually is only in those with pre-existing disease, and it probably is harmful. Again, that's an opinion. But are we actually undercutting the efficacy of ADT by allowing this metabolic syndrome to develop? I think we are. That needs to be tested. We certainly know from our randomized trial, the low-carb diet, again, with some modest exercise, can prevent many of these side effects. And I think the best way to prevent the side effects is not to use ADT when you don't need to, and really focus on those where it's proven beneficial. And for those we're not sure, that's where we should be doing the clinical trials.